就是可能还是要请大家麻烦帮忙确认一下那个 location，像这个 case 啊，这上面写 pancreas，可是它不是 pancreas。然后呢，就是可能发报告的时候，昆平还没来，昆平来了，就是这个 pancreas 的这个啊 ，US 昨天那个它不是 pancreas。它的 location 是 intra-abdominal nominal mass， 所以可能要再注意一下。然后那个可能我们报告不是只打 positive 就好，就是它应该比较像lymphoma，所以可能还是要把lymphoma打出来啊。如果还不确定的话，可能就是等一下，等那个切片出来。So this is from a 50-year-old male. So it is a US guided biopsy, but it is not sample the pancreatic lesion. So it mentioned that the patient had a large abdominal mass. So this is liquid-based preparation. I think for the liquid-based preparation, it's very, very difficult to interpret because most of the time we see these kind of cases, we see adenocarcinoma. Here we do see some relatively bland-looking mucosal glandular cells with nice honeycombing arrangement. The nuclear size is small and uniform. In adjacent, there were some like bigger cell, but the cell membrane, the cell contour is very difficult to interpret. It looks like it's naked nuclear or something like that. And in the background, it seems to be some necrotic debris, but it is very difficult to identify a lesional cell in these specimens. However, we do see occasionally some of these very big cells with irregular chromatin pattern, and it seems to be in really high NC ratio. So I think this liquid-based preparation is very difficult to interpret, that we only have some like degenerated cells in a necrotic background, and it is difficult to determine what would be the nature of these typical cells. However, it doesn't look like adenocarcinoma, right? Because we are very familiar with the morphology of adenocarcinoma, but here we didn't see anything. So then we turn to the direct smear. So in the direct smear, it's much easy to appreciate. So here again, let's take a look of these normal mucosal cell. Right next to it, there are two like very big cells with very high NC ratio. And along this smearing direction, you can easily appreciate that these are all malignant cells, and mostly discohesive. There's no like tight cluster, and occasionally you see these very, very big cells. It looks very bizarre. Okay, so you see this large, highly atypical cell comparing to the adjacent lymphocyte. It is positive. This is positive for malignancy. But what would be the nature of these lesion? So based on the morphology, because it's mostly disassociated, and there is no like arrangement, suggests that it is an epithelial origin. And so most likely it is large cell lymphoma. So if we are considering lymphoma, we usually would go to the Lou-Stan. The stain is not optimal because it shows a lot of like artifact, possibly from delay, like drying. But you can appreciate the like a single cells high NC ratio pattern. So I think this is most compatible with a large cell lymphoma, and maybe we can wait for the result of the biopsy. The biopsy do order some stem for the T cell, B cell, etc. So it seems to be a lymphoma case. So the second case, this is coming from a new patient. He is a 70-year-old male, so it's it's an elder male with hematuria for 2 weeks. So the clinician ordered avoided urine cytology. Additionally, the patient had a really high PSA level. So for the urine specimen, first of all, we notice there are hyperchromasia, not hypercellularity. So we do see a lot of cells. So there are some more benign-looking cells, so look like these with a very low NC ratio. However, in the background, you can appreciate that we do see a lot of individual cell chorioresis, along with a lot of like a degenerated cell. Some looks a little bit histiocytoid, but occasionally we can appreciate that these hyperchromatic cells with coarse chromatin and with a very scant cytoplasm. So the low power feature, the background pattern looks like a high-grade urothelial carcinoma instead of a prostate cancer because of these single cell chorioresis pattern, but the cells are not very well preserved. So we need to look for area if we can see some more well preserved cell for the diagnosis. For this specimen, I think it is not very easy, but you can see occasionally these cluster of cell with more preserved nuclear and chromatin patterns. So I think for this case, we can call this high-grade urothelial carcinoma. So there was a study by Dr. Yang Qisheng when he was in the University of Indiana with Dr. Howard Wu Hejun Yishi. They've done a study for high-grade urothelial carcinoma, and they focused on the specimen with only these type of chorioresis, but very scant of well-preserved cell, but they still conclude that with this background, it is safe to call the specimen high-grade urothelial carcinoma. So I think this is a case of high-grade urothelial carcinoma, despite the high level of PSA clinical detected. Possibly he had 2 different tumor. Because he also had hematuria, which is one of the most common initial presentation for high-grade urothelial carcinoma. So I think we can just confirm the diagnosis. And so the clinician will go ahead and do the cystoscope, biopsy, and the curettage. So the next specimen is a pleura effusion specimen. This is also coming from a new patient, 54-year-old female. So she presents with pleura effusion. So in this pleura effusion, the background show prominent like inflammatory cells, infiltration, mostly lymphocytes. But if you go to like a higher power, you can find scatter of these highly bizarre, highly atypical cells. So it looks like a 栗子 with 2 eyes, very cute. But yeah, but it looks very bizarre. It's bad for the patient. And here we also see cluster of 3-dimensional cells and with bubbly cytoplasm. So this looks like adenocarcinoma. But the background does show a lot of inflammation. So for this type of specimen, sometimes a little bit difficult to interpret because on low power you didn't suspect anything. In the cell block preparation, we do see similar findings. These highly atypical cells. So these looks like adenocarcinoma, and we would do a TTF1 for the confirmation if this is coming from the lung primary. But the morphology is not typical for primary lung cancer. So the next specimen is a parotid aspiration specimen coming from a 83-year-old male. So for this specimen in the background, we do see some hemorrhage. So possibly the lesion is hypervascular. And we also see like tight cluster, looks like epithelial cells. When we go to higher power, these epithelial cell does has abundant cytoplasm. The characters of these cytoplasm show more like dense with granularity. So these looks like oncocytes. So the most common oncocytic tumor in the elder male is a Warthin tumor. However, in the background, we do not see typical granular cystic debris-like background, like what we see yesterday. Instead, we do see relatively clean, along with some hemorrhage. So this is not typical for Warthin tumor. Additionally, when we take a look at these oncocytic cluster, it does show some organization into these smaller Sally nests, like a cell ball pattern, like it is here. Again, you see like a small, like aggregates of cell balls. So the architecture pattern along with the background, it is more likely to be an oncocytoma or nodular oncocytic hyperplasia. So these two type of lesion is basically have the same morphology, and it's no way to make distinction based on the cytology. So because we do have some residual specimens, I order and cell block. So in the cell block preparation, you can nicely see these trabecular Sally nest of oncocytic cells into these like a sheets pattern. So this is compatible with oncocytoma, nodular oncocytic hyperplasia. The major differential diagnosis of this type of lesion would be an oncocytic mucoepidermoid carcinoma. So we've seen a few cases before. Those cases, if you take a look of only individual cells, it's very difficult to make the distinction between an oncocytoma or an oncocytic mucoep. But if you take a look of these architectural pattern, the oncocytoma usually have very tight cohesive cluster, while the oncocytic mucoep usually it's more commonly you will see a single cells or loosely like a cohesive like a detachment of the cell arrangement. So that is the distinction. So I think for this case, we can call these MELAM4A benign neoplasm oncocytoma / nodular oncocytic hyperplasia. So the next specimen is from pancreas. It's a EUS guided biopsy. So we do see very, very scant cells. And the cells, it's forming these tight cluster. It does show a mild to moderate degree of atypia. So we would like to see a little bit more to make a more comfortable, like a definite diagnosis. I think for the liquid-based cytology specimen, the preparation and the preservation of the cell is not very good, so it's kind of difficult to make diagnosis. But you do can appreciate some like atypia in these cells. So then we turn to the direct smear. So for the direct smear, you start to see these more well-preserved tight clusters. So these looks like epithelial cells based on the arrangement. And you can tell that this cell does has like a relatively enlarged nucleus with distinct nucleolus. The chromatin pattern is kind of delicate. So it does has a mild to moderate degree of atypia. I think for this type of specimen, it's important to appreciate the arrangement. So remember that we talk about honeycombing versus drunken honeycombing. So drunken honeycombing means that the distance between these nuclei is very irregular. Some has a very big gap, some is overlapped. So for these cluster, there are definitely some drunken honeycombing pattern that we can appreciate. However, the nuclear polymorphism, the 1 to 4, is not very clear. So we still need to go to the other area to check. So again, for this cluster, it does looks like epithelial cell. It's kind of flat. You show a vague honeycombing pattern. However, if you check the long axis of each individual cells, it looks like it all cross with each other. So we do appreciate some disorganization over here. So now we are thinking that it is likely a well-differentiated adenocarcinoma. So over here, you see like irregular glandular pattern and a little bit more polymorphism. Okay, so I think this is a well-differentiated adenocarcinoma. So when we have very scant cellularity, I will always check with the serum tumor marker. The patient had a very, very high CA199 serum level, 3,000 something. So in this situation, it's always indicate that it's an invasive carcinoma. So I think we can just call this case adenocarcinoma. Despite relatively scant cellularity, but still compatible with adenocarcinoma. So the next specimen is coming from an eye aspiration. So we have a young eye doctor who come back from the States who is specialized in eye oncology. So it was labeled pericardial effusion negative, but it is an eye specimen. So please help me with the location. This is kind of important. Okay. So if you are thinking about pericardial effusion, this is still abnormal. So in this specimen, we see a lot of black pigment, right? It's very, very dark. And these cells are kind of atypical. Okay? So this looks like a melanoma. Actually, the patient, we have received his specimen like 2 or 3 weeks ago. He is a patient of lung adenocarcinoma, and the eye doctor will suspect that there is a metastatic lung adenocarcinoma in the eye. And he claimed that because there are sort of like blood barrier also in the eye, so it is not uncommon. You can see isolated metastatic in the eye, but there is no other systemic lesion. So I was kind of like a doubt about the idea. But anyway, the last specimen, it was very scant. We tried to do TTF1, it's negative. We do see some atypical cells, and those cells does has intracytoplasmic pigmentation. So we signed out last time as suspicious for malignancy, and we consider these could be a melanocytic tumor. And so he decided to do a sample again. So this time he's doing a better job to get more specimen. And I think for this specimen, it is kind of safe that we can just call these melanoma. So we do order a cell block, just try to confirm. Interestingly, I think the doctor do sample a lot of normal structure in the eye. So it is a bit uncertain what's the nature of these tissue. So it has a little bit like a fibrillary or like a smooth muscle type of pattern. And I checked the normal eye like a histology, and it looks a little bit like a ciliary body, which is the specialized muscle control our iris, control our like a dilatation of our iris. So it does sample a lot of these, seems to be normal structure. However, you can still appreciate that in the middle, there were these highly atypical cells with prominent, like a cherry red nucleolus, right? And they are area with more these type of cells. Just too many normal structure to very distract me, but yeah. I think this is diagnostic for melanoma because of these large cherry red nucleolus and this high NC ratio, along with cytoplasmic pigment. It doesn't look like histiocyte, so it is not a melanophage. So this is malignant cells. So we call these melanoma, this type. So just within these months, we have 2 eye melanoma. That is kind of unusual, but because we are now in a large tertiary hospital with a lot of specialized doctors, so now we are getting some more like a strange specimen that we don't usually see. So the next specimen is a thyroid aspiration. I'm sorry, it's not thyroid aspiration. It's the aspiration from a neck lymph node. So whenever you see a neck lymph node with this type of cystic, like a hemorrhagic cystic background, it is not normal, okay? And the most common scenario, especially in the head and neck lymph node, it is likely a metastatic papillary thyroid carcinoma. So we need to look careful to see if there is any epithelial cells. Sometimes it will present as the appearance of cyst lining cells, so you can see these spindling like a skull of fish pattern, but you do appreciate there is a pseudo inclusion over here. For some reason, it's not very clear on the television, but yeah, it's okay. Okay. Yeah, so we do see scattered cells, more preserved, and we do see pseudo inclusion. Here is also a cluster of epithelial cells. It's kind of tiny. The ground glass chromatin is not very clear, but you can still appreciate the oval shape of these cells. So the patient does have a past history of papillary thyroid carcinoma. So this is compatible with the recurrence of the papillary thyroid carcinoma in the lymph node. So the next is a thyroid aspiration. So for this specimen, in the background, we do see some colloid. We do see some histiocytes, suggests that it shows some cystic change. It is paucicellular. Before we jump to the conclusion that this is a benign goiter with scant cellularity, we still need to check the morphology of the follicular cell that we can find. So for this case, when we go to higher power, this follicular cell doesn't look normal. So it does show elongated, like a shape of the nucleus. Some nucleus show a little bit irregularity of the membrane, and the arrangement is not honeycombing that you can appreciate. So we were thinking, okay, this looks a little bit like papillary thyroid carcinoma, but the cellularity is pretty scant. So we need to see every cluster to confirm if we can make the diagnosis. Again, for this cluster, it is the nucleus of these follicular cells are slightly enlarged, and again, you start to see like a powdery or ground glass type of pattern here and there, but still with a kind of scant cellularity. And we go to the direct smear. So we have a more like a three-dimensional cluster. Again, the cell morphology here is suspicious for papillary thyroid carcinoma. So for this case, due to low cellularity, I think it's better for us not directly call these PTC, but just call these TBS5 suspicious for papillary thyroid carcinoma. But for every cell cluster that we see, we do appreciate there are a certain degree of nuclear change that is suspicious for papillary thyroid carcinoma, despite the low cellularity and the background of colloid. So this is what we call suspicious for PTC. So the next specimen, also a thyroid aspiration specimen. On low power, you see quite some cellular cluster, but very scant colloid. And for these cluster, you can appreciate that there are some microfollicle arrangement. Okay, depending on the sampling method and the size of the needle, sometimes we can get the large chunk of a cluster of microfollicle. So these almost like a tissue biopsy. So imagine that the core tissue just placed in the smear. So this looks like aggregates of microfollicle. So based on this pattern, this is compatible with follicular neoplasm. So we sign out the case as TBS4, suspicious for follicular neoplasm. So the next specimen is coming from an axillary lymph node. So it is a lymph node aspiration from the middle-aged female. So for this lymph node aspiration, you don't see any lymphoid component. Instead, you see a lot of these tight clusters suggest they are metastatic carcinoma. When we go to higher power, in the background, we do see a lot of cell necrosis. This cell shows hyperchromatic pattern, along with some of the cells showing these like a spindle pattern. And for the nucleus, we do not see prominent nucleolus. So it does give you a little bit squamoid feature. So if this is taken from the head and neck, the first diagnosis would be metastatic squamous cell carcinoma. This would be our first consideration. However, it is in the axillary lymph node in a middle-aged female, and who happen to have like a palpable mass lesion in her breast. So this is most compatible with metastatic ductal carcinoma. So for the breast ductal carcinoma, it is very common that the cellular morphology will show the squamoid pattern, hyperchromasia, a little bit polygonal to spindle. So this is a very common morphologic pattern for breast ductal carcinoma. So this is compatible with metastatic carcinoma in the breast. So the final specimen is a pap smear coming from a 71-year-old lady, so quite old. This is kind of a troublesome case because we received the pap smear multiple times in the past few years. So initially, I think we signed out like possibly 6 or 7 times of ICO, and she already received the hysterectomy during this like examination, And the pathology report of the hysterectomy only show erosion in the cervix. And then after the hysterectomy, she still had a couple pap smear for follow-up, and we signed up possibly 2 or 3 times of high CO. So again, for this specimen, it does show some like overlapping cells with hyperchromasia. It's a little bit difficult to see through. So without the prior knowledge, I feel like to sign out this case of CIN2 because we can definitely see some area looks like it does show a feature of dysplasia. So let's take a look at these highly hyperchromatic spindle cells along these more intermediate cells. But because she had a multiple biopsy, suggests nothing happened, so it shows a discrepancy. Nowadays, she only had a vagina mucosa, no cervix, but we do see these plastic cell cluster. So I'm debating that should we call this CIN2 or possibly we just call this dysplasia cannot exclude high CO. And so finally I decide let's just call it dysplasia cannot exclude high CO. So I think she will also receive a biopsy again and possibly without any finding again and keep like follow up by pap smear, and then we will see some very typical cells. So this is kind of difficult, but yeah, that's the real world situation. So that's all the case for today.
Thank you.
So Louise, I need to go to the university in the afternoon.
Okay.
And so let's try to review the case